So now you move over to our next session, the tele-ophthalmic session. I invite my co-chair, Dr. Sabishach Patnaik, to take the dais. Moderated, Prasanna, Dr. Prasanna Venkatesh. And conveners, Dr. Abhishek and Dr. Sandeepak. Please be seated out. You only Sandeepak and so don't come to the dais. I invite panelist, Dr. Senthil, Dr. Sanjeev Mittal, Dr. Dinesh Garg, take the chair, please. Panelist, you're a panelist. Dr. Kanwaljit, ma'am, please do come. Dr. Madhuri Dikshit, are you there? Madhuri madam, are you there? So, I think we are already late by 10 minutes. Excuse me. Yeah, please. Thank you. Sir, I'm so sorry. I'm so sorry. I'm so sorry. Because we have to leave again time by 11:45, we have to leave the hall. Panelists can sit in that dais. So, can you show me your slides, please? So, I welcome you all to the TOSI session. I must thank Dr. Namrata Sharma, our Chairman Scientific Committee, and President of Congress, Dr. Lalit Verma, giving an opportunity for us to have a session. Initially for 60 minutes, they extended to 75 minutes. I really thank them. And as the time is very short and we got 10 speakers, I request all speakers to make it very brief, complete within 5 minutes. So let me have the introduction slide, please. 6 minutes, 1 minute extra, 5 minutes. Can I have the introduction slide, please? Introduction presentation. So, Dr. Venkatesh, Prasanna, 5 slides, please. So, I am happy to announce that we have completed 4 years of our session, society. Our society was launched on 4th April 2021 during the COVID times. And of course, it was virtually we launched the session in presence of all the dignitaries like TSI president, then AIOS president, and our president, Teleophthalmic Society president, all the executive members, and that day it's a virtual program. And today, or rather, we completed yesterday 4 years. Today, the 4th anniversary of our Teleophthalmic session. I'm a Teleophthalmic Society. I would like to show my slides, please. No, this is not. Introduction. One is introduction. There. My name is there. Professor BNR Subuddhi. First one. This one, second one. Yeah. This one. My next speaker, please get ready for the next dais. Professor Dr. Madhurya, please be there. There are 2 sides. There are the presentations are there. So once one talk is over, other person can come and start the. So I welcome you all to the 4th anniversary of TOSI. Just before that, I want to play a video. Video chala hai? तीन मिनट एक इसके बाद बोल के चले जाए ना नो प्रॉब्लम हाँ जस्ट 2 minutes why don't I make it faster after this after Dr. Madhurya you can talk your talk is good yes please give the sound please नहीं साउंड नहीं चलो कोई बात नहीं लास्ट के भी देगा गो टू द प्रेजेंटेशन में वो आता है साउंड आता है प्रेजेंटेशन में गो टू द प्रेजेंटेशन
What is the delay, sir? Why is the delay? Shall we start?
We already started, yeah. We already started. चलो 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 उधर चला उसको चला लेट इट कंटिन्यू प्लीज कंटिन्यू दैट वन लेट इट
सामने देखिए सर.
Welcome to the 4th anniversary celebration of the Teleophthalmological Society of India. 4 years of transforming eye care through innovation, accessibility, and collaboration.
कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना.
Founded on the 4th of April, 2021, TOSI set out with a bold vision to bridge the gap in eye care accessibility through the power of telemedicine. What began as an initiative has now become a movement, improving lives across the nation. Over the last 4 years, TOSI has revolutionized eye care by conducting a lot of teleconsultations, bringing quality eye care to underserved rural communities, empowering healthcare professionals with cutting-edge tools and training. Through technology, TOSI has made vision care accessible to thousands, eliminating barriers of distance and cost. Behind every teleconsultation, there's a story of lives improved, barriers broken, and hope restored. Here's what our patients and partners have to say about TOSI's journey. As we celebrate this milestone, we set our sights on an even brighter future. TOSI aims to expand its reach, embrace AI and advanced technologies, and make quality eye care a fundamental right for all. None of this would have been possible without the unwavering support of our members, partners, and the community. Together, we have created a legacy of hope and innovation. Thank you for being a part of our journey. Here's to 4 years of innovation, compassion, and progress. Together, let's continue to revolutionize eye care and make a difference. Happy 4th anniversary, TOSI.
Thank you very much. So we have completed the 4 years of our society. I wish So I am running through the slides. I don't want to say much. This is registered on 4th February 2022. This is our mail ID and this is our website. This is our governing council, and these are our objectives of teleophthalmology: eye care service accessible and affordable at remote areas, and also knowledge sharing along with ophthalmologists, optometrists, and nursing officers too. So these are our future access active membership drive. Establish a teleophthalmology network throughout the country and reach the unreached. Nationwide teleophthalmic screening of diabetes and glaucoma, and affordable teleophthalmic setup in everybody's clinic. That is our aim. And shortly we are coming with the journal also associated with the JP Brothers. The first issue will be released on most likely June last week. So I request all of you to help us giving the articles for this program and journal. And these are my session speakers and moderators. So thank you very much for joining with us on this occasion of 4th anniversary of Teleophthalmic Society of India. Thank you. Now it's over to our next speaker, Dr. Lakesh Madharia. May I request Dr. Kim to please do come and your next talk, please give.
Thank you, Dr. Subudhi sir. First of all, give congratulations to Professor Subudhi sir for this beautiful introduction of TOSI. Respected chairperson sitting in the dais and the respected audience of the dais. My topic on TOSI is the overview of the teleophthalmology, is it and its importance, modern healthcare. I am Dr. Madharia. It is an imaging invention, but who would ever wants to use one, according to the Rutherford. The teleophthalmology, it contains the introduction definitions of the teleophthalmology, histological prospects, teleophthalmology in India, the way and the mode. Introduction and the teleophthalmology, the broad term related to the all healthcare services, includes remote clinical as well as the non-clinical services such as training, administrative meeting and continued medical education. Telemedicine, the use of medical information exchange from one side to the another via electronic media. The WHO, the delivery of the healthcare services where distance is a critical factor by the all healthcare. As we all know, the number of the ophthalmologists in India is very much less than what is required. Here comes the role of the teleophthalmology. In the remote area, we can collect the information from the remote area and it can be diagnosed into the main places by which we can give the diagnosis and accordingly we can treat it. The way of communication, the point to point, one patient with the one specialist doctor, one patient connected to many specialist doctor and multiple patients connected to multiple specialists. This is the way. At one place the patient is sitting and through the media it was brought into the main hospital. It could be district hospital, medical college or the institute. This is the same way from one patient, he can be connected to one doctor, or many doctors he can be connected from the rural to the urban area. This is again by teleophthalmologists, the unreached area can be reached from the remote area, it can reach to the district places and it can be taken the advices from the specialist to the super specialist person. Usually it was introduced the teleophthalmology in India. Ophthalmology is largely image-based branches. As we know, one ophthalmologist is for the 1 lakh population in India, 70% ophthalmologists they are practicing in the urban area where the requirement is more in the rural area. So with the help of teleophthalmology, we can cope with this. Then the challenges in teleophthalmology in the connectivity, stable internet connection is a must. Then the lack of the trained personnel, not everyone is confident about making the diagnosis. Then the detailed examination is compromised. No measurement of the visual acuity. It is relatively new, so maintain the sustainability in a long term has to be looked into. This is the different tools in the teleophthalmology and digital cameras and reticam, it is important, the video conferencing, and these are the projects run in India, in the Madras Research, Diabetic Research Foundation, Rural Community Program in the Tamil Nadu, and it is well, then it is also in the Shankar Netralaya and in Arvind also, and this is a app decided by the government. The importance of that was in diagnosis the cataract. We can diagnose the corneal problem in glaucoma, in retina, everything we can diagnose by this. So in conclusion, the teleophthalmology here to stay beyond the pandemic, need to modify our practice as percentage updated telemedical guidelines, repeatedly stress and limitations of teleophthalmology and make sure that patients are aware of need to visit the hospital. This is very important. Teleophthalmology awareness and limitation must be recognized and medical legal consideration has to be taken. Thank you very much. Thank you.
Thank you very much, Dr. Madharia. Please be seated. We will have a discussion at the end of the session. I request Dr. Kim to start his talk.
Thank you, Dr. Subudhi, and congratulations to all the members of TOSI on this 4th anniversary. AI in artificial intelligence in teleophthalmology is definitely playing a major role, and it is shaping how we diagnose diseases. Started with diabetic retinopathy, that's a low-hanging fruit. Been doing this diabetic retinopathy screening for 20 years, doing a manual grading, but with the use of AI today, you can change it, and we have put it in 2 use cases in primary care centers and diabetic clinics. In the last 5 years, we have screened 1 million eyes in the recent times, just identifying diabetic retinopathy. Today, we are also working on glaucoma, age-related macular degeneration, identifying cataracts, trying to find AI tools for diagnosing corneal ulcers, whether it is fungal or bacterial. If this can be done at the rural areas, then it becomes all the more easy. For retinopathy of prematurity, we are going out into the NICUs, doing a telescreening, and now we are adding an AI tool to it. Of course, it's not independent yet like in diabetic retinopathy, but it has to be validated and certified, then it can become an independent tool, independent of any grader. So it is a work in progress. AI helps in identifying fluids in conditions like age-related macular degeneration, and this is another AI tool that we are using for analyzing cataract surgery, just to identify training the ophthalmologists in their surgical skills. How do you quantify them? So this is being done using AI. Federated AI learning is another big thing that's coming up, mainly because this will facilitate secure global collaboration using a lot of data. Today, that is the key. So we will get a lot of insights into patient eyes. We're also working on using just the external fundus, just a smartphone camera taking an external eye photo and trying to find out certain biomarkers like EGFR, HbA1c, and few other enzyme levels can be identified just by taking a photograph. Remedio has shown there are a lot of systemic diseases that you can diagnose using AI tools. So these are all work in progress, and a lot more you can expect. And this, why in teleophthalmology, this will make screening a much more easy way to identify or diagnose systemic diseases from remote locations. So this is the way to go. AI is going to bring in a lot of changes on how we practice. Thank you.
Thank you, Dr. Kim. I think we have to run. So will you have some time after the Oh, I'm so sorry. Please, any question to Dr. Kim? One question? Anybody? One question to Dr. Kim. Well, he is our president-elect of Teleophthalmology Society of India. So,
thank you, sir, for
Dr. Puri, Dr. Manoj, please.
guidelines.
Mike, please.
So the bacterial and fungal corneal is just by taking a slit lamp photo or even a cell phone photo of the patient, the AI tool can analyze that photo and say whether it is bacterial or fungal, just by the configuration of it. It's a work in progress. We are getting certain this thing, but it's still a lot of, like we are also working with Casey Institute and then one institute in Australia. So these are all things that will come in future. I'm not saying it's right there, but the sensitivity has to increase with time. The more pictures it is exposed to, the better it will become.
Thank you, sir. Thank you. So now I request Dr. Manoj
Thank you.
Mathur, our treasurer of AI and the member of our governing council, to give us the teleophthalmology guidelines.
So thank you, Dr. Subudhi, for that introduction. Let me speak about the government guidelines in telemedicine. Basically, during the time of COVID, an amendment was incorporated into in the Indian Medical Council Professional Conduct Etiquette and Ethics Regulations 2002 by adding Regulation 3.8 titled as Consultation by Telemedicine in the said regulation. So the very definition of telemedicine, World Health Organization defines telemedicine as the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, prevention of disease and injuries, research and evaluation and the continuing education of healthcare workers with the aim of advancing the health of individuals and communities. Then they have specifically defined an RMP as a registered medical practitioner is enrolled in the state medical register or the Indian medical register under the said act. The definition of telehealth, the delivery of and facilitation of health and health-related services, including medical care provider and patient education, health information services, and self-care via telecommunications and digital communication technologies. In general, telemedicine is used to denote clinical service delivered by the registered medical practitioner, while telehealth is a broader term of use of technology for health and health-related services, including telemedicine. So, the mandatory online course was suggested by the government. Still nothing has happened, so I need not skip. The online course, it is yet to be introduced. We were supposed to enroll in it, take a sort of a certification from that, and then practice telemedicine. But as on date, it is not in vogue. So basically, the guidelines for telemedicine in India are divided into 7 aspects. Number 1, the context of teleconsultation, identification of an RME and the patient, identification both ways, mode of communication, consent, type of consultation, patient evaluation, and patient management. So the RMP should exercise their professional judgment to decide whether a telemedicine consultation is appropriate in a given situation or an in-person consultation. They should consider the mode of technologies available for their adequacy of diagnosis, and the RMP shall uphold the same standard of care as in in-person consultation, but within the intrinsic limits of telemedicine. Mind you, there is no immunity. Tomorrow, if something happens, the case is filed in the court of law, you can't complain, entertain immunity saying that it was only a teleconsultation. You are perfectly liable. The patient should verify that and confirm the patient's identity. Where the patient is a minor, after confirming the age, teleconsultation is allowed only if the minor is consulting in presence of an identified adult, and every RMP shall display the registration number on prescription website and electronic communication. Multiple technologies can be used to deliver telemedicine consultation. Primary 3 modes: video, audio, and text. Basically, video consultation is essential for primary consultation. There may be situations where, in order to reach a diagnosis and understand the context better, a real-time consultation may be preferable over asynchronous exchange of information. In that case, you need to examine the patient with a physical consultation. Then the consent. The consent, basically, there are 2 types of consents, implied or explicit, depending on the following situation. If the patient initiates the telemedicine consultation, then consent is implied because he has approached you. Whereas an explicit patient consent is needed if a health worker, RMP, or a caregiver initiates a telemedicine consultation. If the consultation is initiated from your side, it is explicit. You need to have a proper consent. If the patient initiates the consultation, that is implied. Then the patient information, the RMP should use his or professional discretion to gather the type and extent of the patient information, and information should be supplemented through conversation with the healthcare worker provider. And if the RMP feels the information received is inadequate, a physical consultation should be mandated. And telemedicine, as Dr. Madharia and Dr. Kim said, like it has its own set of limitations, and in-person consultation in such situations may be required. The guidelines for telemedicine, basically first and follow-up consultation means the first consultation should be a video consultation and adequate steps should be taken. Follow-up consultations can be done through telemedicine or whatever is the necessity. Because of the paucity, Dr. Subudhi restricted my 2 minutes, so I have to rush through the slide. Basically, the patient management, basically, when you are prescribing medicines, you need to follow this list, like TIA list O, which over-the-counter medication, A, with a video consultation, B, after a video consultation, if you need to add medication, you can, and prohibited list should never be prescribed. And there is a particular format for online consultation where you need to specify your degree, your name, your registration number, and all these things have to be incorporated. Thank you very much.
Thank you, sir, for hurriedly going through the guidelines. These are very elaborate guidelines.
Yeah, sure. Professor, it is a 6-minute talk, don't worry.
Yeah.
Sir, I would like to add one thing. In India, like you said, they have not included this telemedicine in the medical course, but other countries they have started doing it. Like in United States, they have included this
Yes.
in the medical courses.
Yes, ma'am. Basically, necessity is the mother of invention. Luckily for us, COVID didn't prolong much. Had it continued for, say, another 6 months or so, these guidelines would have come.
Yes.
The government was busy doing the main things first required things, and this took a backseat.
Yes.
Actually, it is evident, like if they really float an online course, it would be better. I think the NMC should take care of this. They should suggest an online course. We should all go through that. And from AIOS side also, I have it in mind. I delayed it deliberately last year, probably in the next 6 months. I may be trying to roll out a basic teleconsultation app from AIOS side for us, because the government has not initiated much. What we will gain by initiating app straight away is at the back of my mind.
Thank you, but
great.
we need
That's
support
great.
from AIOS.
Yeah,
As you
yeah. There should be some platform rolled out from AIOS, teleoptel and other things. So on a user,
Even if not for primary consultation, for a follow-up consultation or
Today
this,
we have
a basic
on a use and pay basis or something, it should be done.
Guidelines we should prepare from
Unless
the
you have 200
AIOS.
members, you can manipulate. Yeah,
I
please.
think we'll go on to the next talk, which is a very important talk, and the role of teleophthalmology in ophthalmic trauma, because this is the real emergency area in ophthalmology. So very few of those emergency areas where ophthalmologist is called in. Dr. Purinder Bhasin, who is the president of the Ocular Trauma Society of India.
Thank you.
Dr. Bhasin, please.
Thank you, Dr. Garg. And at the outset, I would like to thank Professor Subudhi and all the chairpersons on the dais and in front of me. I'm Purendra Bhasin. Next slide, please. It's not. Teleophthalmology, we know what it is, and but coming to the ophthalmic trauma, it's a leading cause of preventable vision loss affecting millions of people every year. In India, ophthalmic trauma is a significant health issue due to road traffic accident, agriculture injuries, and native sports especially, and industrial injuries. Vast geographical and socio-economic disparities, lack of access to specialized eye care in rural regions, all these things are challenges in our country. And with the advancement in imaging technologies, high-speed internet and digital communication tools, teleophthalmology can bridge the gaps in healthcare delivery by connecting underserved areas with urban centers of excellence. So, what is the global challenge? Epidemiologically, WHO says that there are over 2.5 million cases of eye injuries annually occurring worldwide, and more than 5 lakh cases leading to permanent visual loss. So this is the magnanimity of the problem associated with ophthalmic trauma. And in India also, it is the similar condition. The road traffic accidents are the most common cause of eye injuries, with over 1 million cases of trauma-related blindness or severe visual impairment recorded annually. Industrial and agriculture accidents also contribute significantly to the burden of ophthalmic trauma. So, needless to say about the types of ophthalmic trauma, we all know the impact of ophthalmic trauma is that both physical as well as socio-economic, because there is a loss of vision to the patient, and at the same time there is a loss of productivity and increased healthcare costs. So, what are the challenges in treatment? There is a delay in treatment because of the poor access in the periphery of our country, inadequate infrastructure, and there is the limited availability of diagnostic tools in the periphery and the skilled professionals in the periphery. So these are the three most important challenges. So what is the role of ophthalmology? The remote consultation and diagnosis can be done, and we can do it in a center, and we can triage the patient, whether the patient require immediate care and immediate consultation, or they can be treated over there itself. Like we can see Sometimes a subconjunctival hemorrhage patient comes from distance, and the child is having subconjunctival hemorrhage due to any reason, and they will come from distance to consult at the center. So emergency response integration and integration into the this emergency response integration should be managed, and on-site access should be given, and training and capacity building, that is the most important thing at the moment, which has to be adopted in our country. So what are the benefits? There is an increased access to care. We can manage the cases timely, and treatment can be done, which and with the delay, whatever problems occur, and increase in the infection and damage to the optic nerve, etc. So they all can be avoided, and it is a cost-effective way of management, and there is an improved health outcome. Faster interventions in trauma cases lead to better recovery rates and reduced complications. The challenges are technological barriers, and because poor internet access and all those things are there, and which are still prevalent in our country. Quality of imaging, the poor quality imaging will decrease the consultation. There are regulatory issues which has been rightly highlighted by Dr. Mathur, and training and adoption, that I should say peripheral staff training is very, very important, which should be taken care by the Teleophthalmology Society of India along with AIOS. And availability of teleconsultation during odd hours in trauma emergency, which has to be adopted, which can be done through the Center of Excellences. Various case studies are there, as in India, as Professor Kim was telling, in Arvind Eye Care Center, they have started it for diabetic retinopathy, and they have been very successful in that. In Tanzania, which is a country like us, and emergency trauma networking has been done, and it is successful. In US military, they have adopted it, and in the field, they use remote consultation with ophthalmologists, which has been proven to be a very effective way to provide emergency care on the front lines. So these are some models in India from Arvind Eye Hospital, Sankara Nethralaya, and AI-based diabetic retinopathy screening by L.V. Prasad Eye Institute, etc. So various gaps are there, as has been highlighted by Professor Madaria. India has only 20,000 ophthalmologists for a population of 1.4 billion population, meaning one ophthalmologist for 70,000 people only. So that is very less ratio. And 70% of the population lives in rural areas, but 80% of eye care specialists are in the urban centers. Mobile internet penetration in 54.5% only till 2023, which has to increase to 100%. And no clear legal framework or for the AI-based diagnosis or remote prescriptions for eye diseases, and which has to be taken care by AIOS. Low insurance coverage. Only 5 to 7% of telemedicine consultations are covered by insurance providers. So what is the future? Future is AI driven, as has been rightly said by Dr. Kim. Portable, affordable diagnostic devices. Integration of just 30-40 more seconds. Integration of teleophthalmology with EMS system. Expansion in developing countries to improve global trauma care. To conclude, teleophthalmology facilitates remote consultation, enables timely intervention, provides an efficient diagnostic platform, and we call for action is continued investment in teleophthalmologic infrastructure, AI technologies, and training programs that will be crucial for the future of trauma. Various cases are there. I had a case of post-keratoplastic consultation during the COVID-19, which has suddenly occurred. So with teleophthalmology, we could take the pictures of the patient and send it to our cornea specialist, so we could manage, and this way the graft survival was successful. And other things are also there. Various studies from China are there, which has given us the real-time picture and effect of teleophthalmology in their country. I thank you for your patient hearing.
Thank you, Dr. Bhasin, and thank you for finishing in time. And next we have our president, Dr. S. Natarajan. And he has many feathers in his cap, and this is one of those. and he is the president of Teleophthalmology Society. Screening through teleophthalmology to prevent diabetic blindness, stop blindness. जोत से जोत जलाते चलो.
Thank you, and so that's what as a president of All India Ophthalmic Society, I made this we did about 3,000 camps in the November, and thanks to Dr. Subodhi, who is also doing a lot. So the diabetes mellitus is now the epidemic of 21st century, and this is what we are trying to educate people. And teleophthalmology is the important thing where we can create awareness, screening, and also make the patient come for treatment. So it's a major cause of blindness in the working middle-aged population, and fifth cause blindness globally. And the IDF says 537 millions are having diabetes. And actually right now Lancet has published we have 101 million diabetics as of now in India. 58 million do not know they have diabetes, and that's where we are working in our Mumbai slums. And we have only one ophthalmologist per 100,000 published in Indian Journal of Ophthalmology. And 70% of the Indian population reside in rural area, low awareness or ignorance, and thirdly, follow-ups are required once you are diagnosed. So the technical difficulties which a problem in India is unreliable internet coverage, deficit in supply of electricity in many areas, shortage of trained medical staff for operating conventional fundus camera, and portability of conventional fundus camera. So these issues can be solved using a computer machine learning, AI, for analysis of retinal images in people with diabetes, thus solving at least some part of the problem, which is again published by the AIMS Atul Kumar and group in 2019. And AI, the intelligence is the capacity to analyze, think, make a decision, and categorize. And artificial intelligence involves formulating a specially made algorithm according to our needs to develop this capacity and include it in an electronic device like smartphones. I saw this in 2017 in Ahmedabad in an diabetes conference, and that's how I picked up this. And then we got the AI integrated into which can perform fundus photos, identify fundus feature, classify image, classify existence and severity of the disease based on tableting. So the idea is to screen, diagnose, and treat. In cancer, if you screen and diagnose, and if you don't treat, you are punishable according to the Indian Penal Act. In diabetes is not there, so morally, I think all general practitioners, diabetologists, and optometrists, ophthalmologists have to be involved for not only diagnose, you have to make sure the patient comes for treatment. As a part of our NET study, we had a problem. Patients are not willing because they said, my vision is good, why should I get a laser done? So we need more working hands, and we have to use a minimally trained staff, and we arm them with AI, and that's what we have done. We have made a pre-camp awareness, assembly of diabetics, capture of images, and diagnosis can be done by AI, ophthalmologist, and then so we work with Remedio, again, no financial interest, and I don't know whether they become industrial partner. Dr. Subudhi and me are trying to tell all the manufacturers of the various teleophthalmic instruments for becoming industrial partners so that they can pay money and also be part of it. And instead of promoting them, we want to promote that using any of the equipment we can screen. So here we have used non-skilled health worker who are working, who can school dropout. They know to use the smartphone, and then they have been trained to use AI, which is deployed on a smartphone and using in the municipal dispensaries from 2019. And the computer is trained to accept retina pictures, and then that labels as this is how the iPhone is attached to the infrared device with an adapter. It can be mounted on a suitable bike, can be mounted on any table, and it's chargeable. And this is made by Forus. As I said, I'm not supporting any company, but I want technology to reach every village in India. We have 6,47,745 villages in India, and you can see my late grandmother and late father who inaugurated this van where we carried the motorbike, the camera in the motorbike, and this is what. So you can see this is we can carry this thing in the motorbike. The reason is by sending a non-technical person, that's important because we don't have to waste the power of ophthalmologist and optometrist. And this boy is a 9th pass, and this hardware is in the box, which is kept in the, thanks to Forrest who made this for me in 2014, and we inaugurated on March 1st, 2014. Which I saw it in Agra All India conference. And this is you see the bumpy road. We can bring this sort of cameras which will not be affected in if you take a Zeiss or Topcon, the whole optics will go. And you can see this guy takes wonderful pictures, and then AI can say this patient needs to come to the center for referral or for treatment or not. And usually if you diagnose 100 patients, you will have only 5 patients may have to come to the clinic. And we want to target that 5 patients so that with a good vision, and we have a retinopathy, and then we can use them for anybody can screen for diabetic retinopathy. In all these pictures, whatever you see, if the fovea is not involved, the patient will have 6/6 vision. Does not mean his eyes are all right. So that's why we have to use the teleophthalmology to bring the patient for treatment. And we also did a Guinness record where we are using this Remedio camera. We can see that all of these guys can take excellent pictures, and you can see this optic disc. And now this Remedio has come out with the 3 diagnoses: diabetic retinopathy, glaucoma, and age-related macular degeneration with one. And this Medios is the software which is incorporated in the mobile phone. The blue thing which is identifying the discoloration in the retina, and with the base images in the mobile phone itself. We don't need internet. So that's why in 10 seconds the phone will diagnose and tell the man that this patient needs to be referred or need not be referred. And the rest of the 90 people or 95 people can go, and every 6 months they can have a retinal checkup, or every 1 year, and also get the diabetes checked. This is a comparison on fundus on phone with size, and this is the AI which covers and classifies the diabetic retinopathy and sends the patient. So this can be the link between medically underserved area and tertiary healthcare services. So we can have physically somebody going, but transmitting the images to the center. Later all these images can be kept in a data server, and which can be used and analyzed by the ophthalmologist, by the epidemiologist, and then also for follow-up. And that's how this program Stop Blindness as an AIOS initiative was done. We made a public interest movie inaugurated by Vijay Amritraj and Andre Agassi, the tennis players. We came in the Guinness record. 649 patients where we assembled and did the screening. 53 needed treatment, and we treated them free, and that's a record created. The idea is to create more, and then this is a research question we asked, how to use the AI, and then 100% sensitivity, which is published in JAMA in 2019. And the American Academy courses said this is the future, but I'm happy to say we are leading the world by doing this in India, and with more patients in the IGO. And then this is what we want to use, and also working with the various endocrinologists and other physicians to comorbidities can be diagnosed in the same patient, so that we can help the patient to live well, see well, and also live happily. And every day I quote our Rakesh Junjunwala, who died of, actually the paper said a heart attack, but he actually died of diabetes. And what is he created a wealth of 45,000 crore, but he could not enjoy it, and he was in wheelchair when he went. So by doing the diagnosis early, refer by the eye doctor, and then refer to the other specialties like cardiologist, neurologist, and for foot and renal specialists, we can prevent them from spending a lot of money. Early referral of the diabetic patient, greater care for the for the eye, timely medical surgical intervention to prevent complete loss of vision, and we create job opportunities. We don't need the UP police is there, Romeo police, we don't need them, and we can develop skill development in the less educated, and that's why I made a foundation to do this, and this is what we want to reach 6,47,000. We are now doing with all the, this is what we educate the patient, that diabetes affects the body, and through the eye we can diagnose. And so this is the last slide. I think AI is likely to be the best or worst thing to happen to humanity. It is up to us which one it's going to be, and we have to be the master of AI, as Stephen said. We have to make use of it, and then teleophthalmology will be the. So this is what the 3 slides we brought in that movie. So I think using AI, using teleophthalmology, we can prevent not only blindness, we can make Indian people live well. If we diagnose from the age of 40, they can live till 80 healthily with a good vision. That means they'll be contributing to their own income, thereby per capita income increases and GDP will increase. Thank you.
Thank you, Dr. Natarajan, sir, for your nice presentation. You're always traveling, doing lot of good work. Hardly we see you in India. Thank you. Now we have our next speaker, Dr. Rajiv Raman, who he would be speaking on teleophthalmology in 2025.
Thanks the organizers, TOSI, for organizing this nice session. So 2025, Dr. Natarajan already has put the pretext. It's the AI which is governing the world open media. So these slides I prepared by AI. So I didn't use my thing. I had put a prompts. I had made the summary what I want, my flow of thoughts, and actually it even created. This is freely available. It also created avatar. It gave volume, speak over. I didn't use it. So we are in this era today that we can do. So the whole slides are prepared on Gamma. So tele-ophthalmology in 25, the technology reach and the future directions. So definitely not to repeat, tele-ophthalmology is important because it addresses the global vision impairment. We have more than a billion people affected with visual impairment. Geographic disparities are there. And there are scalable eye care delivery models which have been demonstrated. And actually COVID-19 accelerated the adoption. Never thought of having these Zoom meetings, teleconsultations that really accelerated after COVID. So if you just look at evolution of teleophthalmology, 2000s, I think I still remember Dr. Badrinath being one of the founder member of TSI, the Telemedicine Society of India, where we had those big satellite, big vans and the satellite connectivity given by ISRO. We had store and forward. So you used to take the images, take the data, store it, then send at the end of the day, and people used to diagnose. 2010 started the real-time teleconsultations. 2020 we started seeing many of these AI triage and portable devices. We had the home monitoring device, the home OCT, the nodal OCT, which was again devised by in Egypt, in Israel, and people started using these even in retinal care. And in 2025, the more thirst in teleophthalmology is going towards these home-based monitoring devices. Definitely portable cameras are one of the things which are shaping the future, these technologies. The AI interpretation, we have beautifully seen by Dr. Natarajan's talk how AI can diagnose various stages of retinopathy. The data storage, which used to be a big problem at some time, today we have good cloud sharing platforms and 5G connectivity so that there's a very low latency as far as consultations are concerned. Coming to home-based care, there are a lot of these smartphone-based apps. Dr. Natarajan was mentioning about Smart India study where we had used the PEAK tool to measure ETDRS visual acuity in the field. Very well validated device. So we could never have thought that we'll take a logmar acuity in the field, but that's now reality. We are able to do that. I told you the nodal device, the home OCT, it's again which is picking up and people. So it's only a couple of years we'll see patients coming and saying, my fluid is again come, give injection. So I think those things is something which we'll see soon. That's where the teleophthalmology is all moving. There are many global success stories. I would say in India, it is the diabetic retinopathy screening, which has really picked up. Happy to share that the AI integration into diabetic retinopathy screening is not only there in AIOS VRSI guidelines, but even for the physician guidelines, the RSSDI guideline. It talks about all the available AI platforms, the portable cameras and how you can use it. I think a lot of effort has been done in DR screening. Singapore has been leading in various AI platforms. They have integrated it into their healthcare system. They were the first to form the guidelines of using AI. UK, again, people have used in community screening a lot of these AI platforms. And in US, the Veteran Affairs, there are a couple of now work which people are using for reaching out to them and validating many of these AI platforms. However, there are a lot of challenges which we face today, the data privacy, the consent protocol, whether it's an inbuilt consent when you do a consultation itself, you get a consent. Image quality is always a big barrier. Even for DR screening, we know if we take a non-mydriatic image because of our cataract, which we develop in a little early age, nearly 30% of our images are non-gradable and they become referable, so that becomes a problem. Just 2 slides more. And definitely training of paramedical staff is a problem. So the road ahead are these AI platforms, which are decision support systems, mainly based on LLMs, the cross speciality, not only ophthalmology, but having a holistic telemedicine program, and definitely national policies. If we can integrate the insurance integration into these, some work in the field of cardiology has already happened, but in ophthalmology, I think this will go a long way. So to conclude, teleophthalmology today is not just about distant care, it's about equitable care, and definitely future lies in scalability, and collaborative development is something which is very essential to do that. Thank you very much.
Sir, one thing I would like to add, like you said, there is homemade OCT. There are certain apps also available. Like they are useful for the patients, like for exudative AMD, so they can just observe their findings. They are old patients; they cannot go to clinic on the daily basis, so they can just feel they have decrease in the vision and they need injections. So only then they go to the doctors.
I think all these tools will become, so that's why I'm telling 2025 these home-based monitoring systems are gradually having more traction.
Yes, would be very useful.
So thanks Dr. Rajiv Ravan for your excellent talk on teleophthalmology, and you are in fact working a lot on these things. So thank you very much. Now the next speaker is Dr. Jayan Kumar Das. He will be speaking on impact of small scale devices in teleophthalmology.
Slide please. So good morning everyone. So this is the point my previous speaker explained all, so it will be easier for me to highlight all those points. I will skip all those theoretical points. It's not moving. Slide is not moving. Okay. I have no financial relationship. I will skip all those points to save the time. So in Rajiv Brahman is working in a big institute, and to address all ophthalmologists, all paramedical staff, is it possible to do it telemedicine to each and every corner? Right now in our AIOS Kumbh Mela, they are doing so many works in remote areas. Natarajan sir mentioned how we can carry a small scale device in without any damage. So earlier that cost cutting technology also is a teleophthalmology, we can do a cost cutting. Some simple mobile is a good quality in everyone's hand, so we can use it instead of a big mobile van. It's not possible to each and every village because we need a road connectivity also, and big setup is the only issues. Like that, this is my motto, is that earlier in that in our computer big chip, big one, but now is a very small micro. Everything is with the nanotechnology. My previous speaker mentioned poor quality of photograph. What? Yes, this mobile from they're sending me this patient by poor quality, but he was complaining of epiphora, that paramedical, that one probably thought it may need DCT or DCR, but I just asked from the symptoms and the send a photograph. There's a facial pulse. Asked immediately to check the pressure, and he was very much hypertensive. So we can save so many life on that way also. That boy, they are treated somewhere by a simple inflammation. I asked the parents to send that one photograph and then few slips. It is that type of inflammation, and I asked that for a CBC. He was found blood malignancy, that a COVID time. So we can do so many things. That's my earlier I did a observation. Everyone mentioned, so maximum from rural population still. It can be also by a mobile, you can teach my resident, teach my previous fellow who are working in remote areas. So dog bite, he forgot what to do. So from that, he is asking me, so we can communicate each others to on the group. So those are the things you can avail. Is it available or not, that drug? How we can, what are the process to do the repair, etc. Every point. So you just take a clear photo. Previous photo was not clear. Next year sending the clear photo. One patient. It's a retinoblastoma. It was operated in some other Nepal or somewhere. The parents wants to do a COVID time, so they are informed me. So there is again some swelling. Then this is one of the disadvantages I am saying. So for telemedicine, from the looking is not possible. Then I asked to come. Moment I examined, that found CT shows that the ball was migrated to the upper part. So in some cases, there may be some negative results, but we can do. So just recently I want to show one of my patients. Yesterday I was delivering a talk, then there is some WhatsApp message over one of my paramedical water from my hospital. She told, this is the photograph. Can you see that a one-eyed patient? From this, I can say, so now what to do, I just advise everything. So on Monday, I will operate that thing. So that's the point we can do. So the small scale device also works, especially like in India, where there's a huge number of population. It's not possible. Doctor population ratio is very, very thing. And a big setup is a lots of infrastructure. Fund is one of the issue. And there is so many factors. So by a mobile or small scale device, if we can tune up, we can do some collaborative studies in such cases, then if that everyone, that's a blessings for us. COVID also one of the point into teleophthalmology, at least for teleophthalmology, because everyone now knows how to operate, how to send the documents. So it is enough. So this is one of the patient with the communication with the pediatrician. Even in the, I was working in a tertiary care hospital at present. So there's a road traffic accident. The ambulance critical care team and the driver send me this photograph. Then I can understand what we should do. And immediately we can arrange whole team, critical care team was arranged, and next we are doing, we can save the life also. Not only the diagnosis, sometimes we can save the life, we can test. Everyone is tuned with this device. From the business perspective point of view, to improve our practice, we can use it very, very handily. So those are the points I can just communication. Follow-up can be done. So some patient wants to follow up instead of, so is a business impact. Suppose there's a 3-4 employees, you can cut short, just they can ask them to mobile WhatsApp. Instead of by phone call, just I always advise all my patients to my secretary or to me directly by WhatsApp. So that's one way we can cut short so many points, so many things. But there is a few limitations is on previous my speakers, so there's a quality of the picture, especially in case where non-myetic, it is a PSOS. Of course, because for a diabetic retinopathy, it's not possible for dilate each and every patient. The technician is not, for them is not possible to be a gonio, because India is a prone for a angle closure glaucoma. For that point, of course, a poor quality. And especially in case of a glaucoma and in optic nerve
please
disease.
conclude, please
Yes,
conclude.
sir. Yes, sir.
Yeah. Dr. Inder Rastogi.
So just I want to conclude, it is a small scale also works very good. Thank you, sir.
Sorry for the interruption, because already we are late. And of course, we have given 10 minutes late. Our session started 10 minutes late. So, yes, Dr. Inder Rastogi will speak in instead of Dr. Arvind Moria.
Yeah, good morning. Thank you, TOSI, for giving this opportunity. Challenges and way forwards. So everybody has explained what is tele and form of this delivery. So benefit is improved access and cost effectiveness, screening and early detection, and of course the pandemic. Everybody knows about this. So this is the basically picture where how the TOSI or teleophthalmology, provides this thing, the consultation. And main thing is where it is, the image is processed, how we do it, and how the team of the doctors take the decision, and ultimately how the patient is benefited. So why tele is need of the hour? Again, it is because equitable, affordable, and accessible healthcare, and of course, seeing the condition of Indian demography, where the mainly population is rural, we have an edge for this technique. So basically, two types of the telemedicine. One is asynchronous and synchronous. Synchronous is real time and asynchronous is way forward. So how the thing is, asynchronous is mainly used. So program, already this has been discussed. And again, the recent example is Netrakumbh also, Netrakumbh 2025, where, all the ophthalmologists went there and they are guiding the patient over there. So these are the challenges, means digital divide. The India is basically divided digitally, lack of infrastructure, and of course the major concern is data security and the privacy of the patient. We need to have training and capacity building for the force, and of course the initial cost, again that remains the chance. So bias in India, basically we need to have staff in the remote area, and of course the lack of inexpensive mobile imaging device, and public funds where the costs are usually incurred on the initial expenditure, and of course savings that is there. So again, one thing is varied sensitivity and specificity of AI algorithms, and longer loading time because of the poor internet. Multiple images they fail to upload at the same time. So these are all basically the related to the media only. And of course, we need to have an education system where we can train our ophthalmologists and optometrists. So earlier it has been discussed that we need to formulate guidelines on this. So these are the basic advantages. Keeping the difficulties or problems in tele, we have some advantages also. That is, we get improved patient care, referral patterns they are strengthened, and extended patient care, expertise, care to the patient in the remote area. We are slowly educating our staff, and of course another thing is limit spread of diseases. So most effective planning and administrative meetings with the point and click sharing of the content so that we can have immediate result also, video conferencing, and of course the teaching, that is of main thing, that we need to have a curriculum in the syllabus. So overcome bias means education and sensitization. We need to align tele with other programs of the blindness, and we need to go to the remote areas with nice incentive also. We need to have a proper connectivity and broadband. Legal aspect they have already discussed. And again, so we are, the Niti Aayog has already released some guidelines on, but it needs further clarification. So legal and ethical consideration as these things, basically the consent is this has already discussed into this. So conclusion is that digital health is going to revolutionize. We need to adapt ourselves according to the changing technology, and AI technology and tele, they can have innumerable benefits. So fruitful outcome will be there if we go in the right direction. So again, tele is the need of the hour. Thank you very much.
Thank you very much for finishing before time. Thank you.
Thank you, sir.
Now we move on to Dr. Sabyasachi Patnaik, our treasurer of Tele Ophthalmic Society of India, to speak on E-Sanjeevani.
So at the outset, I thank AIOS and the scientific committee for recognizing TOSI as an important entity and providing us the space and time for the session. So what I am going to speak about is ever since we established or we started thinking of forming a society called Tele-Ophthalmological Society, we are struggling for a software. All of us know that ophthalmology best suits for teleservice because our mostly diagnoses are based on images. So images can be taken with equipments and can be sent for tele-screening and tele-diagnosis. So government under its digital health mission have prepared a software, E-Sanjeevani, under National Telemedicine Service. So mostly to take care of shortages of doctors in the periphery, overburdened district and tertiary hospitals, absence of health record creation at primary and secondary level. So there needs to be a continuum of care. So till now it is being used by almost all the states. Our state was not being
using this because of political reasons. So this e-Sanjeevani has two components. One is Ayushman Bharat Health and Wellness Center, where doctor-to-doctor telemedicine system or the hub and spoke model is operating. And the another component of that is e-Sanjeevani OPD, where home-based teleservices can be provided to public. So what are the system requirements for that? Hardware, a simple laptop or a desktop computer, and even a tablet also can work. Camera with speakers, and full color video conferencing can be done with at least 2 Mbps internet connectivity, and a working mobile phone to send or receive OTPs by SMS, because you have to confirm your identity. Software, they advise Google Chrome or Mozilla Firefox is most suited for this thing. So there is a study from PGI Chandigarh about use of e-Sanjeevani in ophthalmology. So these are the conditions they could diagnose through using comfortably the e-Sanjeevani platform, where dry eyes, allergic conjunctivitis, refractive error, cataract, audiolome, blepharitis, almost all the anterior segment diseases can be diagnosed, and e-prescription can be generated as it is there in the left side. So this is how the prescription also can be generated through e-Sanjeevani platform. So there are so many doctors are using it in other platforms, and their names and photographs are there in the e-Sanjeevani website. So government tries to recognize them. Different state governments are also using. So the benefits of e-Sanjeevani in ophthalmology is we can use mostly diagnose the cases, and also by incorporating fundus camera, we can do diabetic and glaucoma screening also through e-Sanjeevani. So my purpose of presenting this is we on behalf of Teleophthalmology Society and also AIOS can work with the government to suggest them that this e-Sanjeevani platform, by incorporating this fundus camera and slit lamp photography, at least in the CSC or vision center level, we can have that, and with this software, we can start teleophthalmology, both OPD, home OPD, and also doctor to doctor, or our ophthalmic assistants who are there in the vision centers and CSCs. They also can consult to ophthalmologists, that they can decide themselves to whom to consult. Suppose in retina cases, they can consult a retina consultant, or any other subspecialty they can decide also and connect with them, and the patients can be benefited directly, not coming to the hospitals. But there are certain challenges. Network was a challenge, but during this budget, Government of India has assured that every CSCs or every block will be provided with broadband platform, and equipments are to be provided, staffs to be trained, little bit of training required, awareness creation, people should be aware about these facilities available near them, and also dedication of the service providers are required. So I think this will be an effective platform to be used by all of us, because government will take care of, because in this tele system there are many issues also apart from sending photographs, because when the government is going to be involved, there are many issues. Mostly the data security is one of the issues. So the system that is provided by the government will be the best and safest for all of us. So thank you very much for your presentation.
Thanks, Dr. Patnaik. Now we have the next speaker, Dr. Chitranjan Mishra. He would be speaking on AI integrated handheld fundus camera based DR screening in physician clinic in rural India.
Thank you, madam. Thank you, TOSI, and thank you, AIOS, for the opportunity. My topic is AI integrated handheld fundus camera based DR screening in physician clinics in rural India. These are my acknowledgements. And I'll be telling about the real life work that we have done in a small yet beautiful city, that is Sambalpur, that is in western part of Odisha, India. And when I returned from Arvind Eye Hospital, Madurai, after my training, I was doing the DR screening in the physician's clinic. As you can see my photo over there, IO over indirect ophthalmoscopy, and this is one of the examples of Dr. Nathan Dora's clinic. So around 4 to 5 clinics are there where I was going, but gradually now we have shifted the practice to a non-mediatic offline AI integrated, that is Remedio. We have been listening for past quite hours in this room itself. So we have trained our optometrist and MLOP girls. They are doing the work now. I need not go to the physician clinic by myself, and I'll just show a small video over here. This is how they are operating, entering the patient's name, MR number, and all the details are entered. Then this is how the photo is captured, and this is all done by the MLOP girl or the optometrist. They are visiting over there, and automatically, the image quality is sufficient, and AI generated image is generated over here, and this is analyzing the data, and you see there are small blue color things are coming. So after this, what they are doing, they are sending the data and in a PDF form to my email ID. So I need not go there. I can grade it sitting in my own clinic. This is what real life we are doing over there in Sambalpur. You can see over there. And now you see this is the PDF that is generated, and it has come to me. So coming to the statistics, you can see over here, say this is for the month of December 2023. So 109 patients examined. How many patients graded? Graded means physically the doctor has graded. I have graded over there, and how many patients they were referred. So this is a March month. We have say 31 patients we have examined, but I am yet to grade anything. But all these patients are AI graded, and report is generated. So this is a very important slide from my talk. Total number of patients screened is 704 in this 1 year, out of which 20% were detected to be DR, and all of them 141 patients. But the catch point is that only 9%, that means only 40% of the detected patients visited us in the retina clinic. That means we need to work hard. Just telling that, okay, you are diabetic, but they are not coming to us. So we need to really improve their knowledge, attitude, and practice, both for the patient and also the physician, because the physician is the first contact with them. Similarly, the non-diabetic retinopathy, cataract, refractive error, pterygium, these patients are also screened and referred. Again, some 41% of those patients only visited the eye hospital. So to summarize, physician clinic-based diabetic retinopathy screening focuses on the target population, that means the diabetics, and this Remedio Foundation phone camera really helped us. No financial interest, and technology and teleophthalmology and platforms like TOSI, they really help in this service delivery. However, the most important part, which we have not discussed over here, is to increase the knowledge, attitude, and practice, so that these patients will come to us. Just diagnosing them over AI platform is not enough. So thank you. I think I finished.
Really.
This
Thank you so much.
Special instruction from Subodhi sir to make your presentation crisp and to the point. So I followed you, sir. Thank you very much.
Thank you very much. Dr. Tarun, are you there? Anyhow, so Dr. Tarun is not there, so I would like to give the concluding remarks. Thank you all for the nice, wonderful session today. And as I told earlier also, today is our 4th anniversary of Teleophthalmic Society of India. We have completed 4 years. May I request all to join to have a photograph with our friend Dr. Abhishek brought a cake to cut. So please wait, sir, 2 minutes. 2 minutes. A cake काट लेते चले Sandeepak and ये please do the honors. One thing we would like to increase our membership, because we have to, as our president said, the affiliation to the society, AIOS is very important. So to reduce, to increase the membership, we want to decrease our, so shortly we'll come with a discounted teleophthalmology, live membership fee. Please, I request all of you to join. And of course, already our treasurer of AIOS is there with us. So he has already spoken about the telemedicine guidelines. So he should give us almost all AIOS meetings a TOSI session, so that at least we can put forth our views on teleophthalmology. So thank you very much for joining with us, all the viewers and all the speakers and all the panelists. I thank everybody for joining with us. Thank you.
So one thing I would like to ask, TOSI is registered?
Yes, I told you.
Yeah.
4th
one,
February
and I think
2000
to increase the member base, I had already requested to reduce the
Yeah,
membership
yeah, we'll
fee.
do that. We'll do that shortly. Sir, sir, please, sir. Sir, please, Asad. Please, all of you, please join with us. Sir is there. In the right.
Happy cheers, 4 years. Happy cheers, 4 years.
Actually, our inauguration date is coincided with the conference. So you celebrate this year.
मतलब विंग्स भी सर 5 लगवाए, 4 पूरे हो गए, 5 हो गए।
अरे यार, thank you.
एक के लिए तो इतनी देर से बैठी थी उधर।
Ma'am, please. Sir, we have one international guest also from Canada.
I would leave the session. Leave the session. कोई आया नहीं? कौन सा क्या टोकन वाला कौन है? अच्छा है। सर ग्रुप फोटो ले लेते हैं। नीरज जी, एक ग्रुप फोटो ले लेते हैं। इधर आ जाए, इधर आ जाए।